Hi, my name is Hailey Charest, and I'm a senior at UMass Amherst in the biochemistry and microbiology departments, and I am also a member of the Riley Lab. Today I'll be presenting to you my honors thesis, which is in vitro susceptibility to Nisin and antibiotic comparators in clinical isolates of methicillin-resistant Staphylococcus aureus. Making MRSA strains not MRSA anymore. So what exactly is MRSA? So MRSA stands for Methicillin-Resistant Staphylococcus aureus. It is a multi-drug resistant superbug that causes over 100,000 cases a year and over 20,000 deaths annually in the United States alone. Globally, 1 in 10 people carry MRSA in their nose, which is why it is so prevalent. Unfortunately, MRSA disease results in high morbidity and mortality, which makes it very important for us to learn how to treat. So MRSA is transmitted from 3 different ways. So the first known and one of the most prevalent is hospital-acquired MRSA. So this is nosocomial infections that are caused by patient to patient, provider to patient, and infected, contaminated equipment spread. Then we have community-acquired MRSA. So what this is, a lot of times, it's spas, healthcare centers, playgrounds, daycares, and imagine a kid scrapes their knee on the playground, they can get MRSA into that scratch and then get a MRSA infection. The third is called livestock acquired, and it is the most recently discovered. So what happens is livestock like cows and pigs, they carry MRSA and then they transmit this to the workers who care for them. And there's research being done to see if it's being carried in our food as well. To treat MRSA, the current treatments are all antibiotics. So our golden standard to use is vancomycin, and our last resort is daptomycin. Other antibiotics are used, but these are the 2 most common. As you can see in the chart below, as different drugs are introduced, resistance continues to be unveiled. So unfortunately, this trend has only continued and the antibiotic resistance crisis is rising. The only thing that they have found success in that isn't antibiotics is just negating the spread of disease by changing techniques in hospitals, being more sterile and cleaner, and that's been able to negate some of that hospital-acquired spread, but unfortunately, even though that's lowering cases, the cases we are seeing are very antibiotic resistant. So what is our alternative that we propose? Nisin. So Nisin is a bactericid, which is a protein produced by bacteria to kill other bacteria. The way it kills is it attacks the peptidoglycan layer of our target cells, and most known is the gram-positives for Nisin to work against, which MRSA is a gram-positive organism. And what it does is it causes a oligomer with the lipid 2 in this membrane and causes a pore to form. What's great about Nisin is once that pore is formed and the cell is lysed, the Nisin can actually go and repeat this action at other cells until it's degraded. Another great thing about Nisin is that there's no known toxicity that has been studied in animal models, and it's also a very highly stable molecule, making it great for research and potential use in medicine. So what my team and I did is we took 118 clinical MRSA isolates from the Cooley Dickinson Hospital in Northampton, Massachusetts, and we screened it against Nisin, vancomycin, daptomycin, and later oxacillin. First, we compared the Nisin minimal inhibitory concentrations determined by broth microdilution with the vancomycin and daptomycin MICs that were determined by e-test, and we found that Nisin was a comparable killer. So we wanted to take this a step further, and since we already knew that Nisin could kill MRSA very well, we wanted to see if we could use a technology called synergy, where you combine more than one drug, to see if a cocktail of Nisin and oxacillin, which is supposed to not work against MRSA, to see if we combine those 2, if we see better killing than either drug alone. So here are the MIC results. You can see that Nisin, vancomycin, and daptomycin are relatively low. While you can't directly compare the number the MIC is at, you can see that they're very close together. So as a rule, all of these drugs work against MRSA, showing that Nisin could be used in this arsenal. However, when you look to the far right at oxacillin, you have that value of 256 mics per mil. And this value is very high. It shows that these strains were very resistant. And while this was a subset of 12 of those 118 strains, it's still very alarming to show how resistant these bacteria were. So next, we decided we were going to do that synergy I mentioned and combined oxacillin and Nisin. So what we have is the horizontal black line shows where the resistance breakpoint is for MRSA against oxacillin. So any of those black bars that go above that line show that those MRSA isolates were resistant to oxacillin. And we had 11 out of the 12 initially resistant naturally, and then that other one is an acceptable value as it falls into a category where you see oxacillin sensitivity within MRSA. So all 12 of these isolates were MRSA. So now we see that when we combine oxacillin with Nisin, those gray bars are where that combination of drug works better than either the Nisin alone or the oxacillin alone. So you can see a dramatic drop. And in 11 of the 12 isolates, we are seeing that you're having that once resistant bacteria now sensitive to a much lower amount of oxacillin. In these light gray bars, you're now seeing oxacillin and Nisin in a combination where the Nisin MIC may not have been improved, but the oxacillin was greatly. So by the end of our synergy study, we found that we were able to have all 12 of these isolates sensitive to oxacillin at very, very low concentrations comparably to their starting point when we add Nisin to the mix. So overall, we found that Nisin is a comparable antimicrobial agent to those first result and golden standard, last resort, vancomycin and daptomycin. And we also found that synergy of oxacillin and Nisin was a great success. A side project that I've been working on in the lab over the last couple of years with a couple of my teammates is a company startup called Backbegon. So what we want is to take our research and turn it into a real product. And thanks to the Berthium Center for Entrepreneurship, we were able to compete, and we're hoping that we can bring our research that we learned through our education and apply it to the real world, making life-changing and life-saving technologies. Thank you very much to Dr. Riley, Dr. Springer, Hadley, Brianna, Andrew, both the Biochem and Microbiome Department, again, the Berthium Center for Entrepreneurship, and Backbegon LLC. If you have any questions, please feel free to email me at hcharest@umass.edu. Thank you.